I'm Alan Helgeson with Sanford Health News. This podcast is part of Her Kind of Healthy, a podcast series dedicated to conversations covering topics from fertility to pregnancy to postpartum, managing stress, healthy living, and so much more. In this episode, Dr. Keith Hansen with Sanford Fertility and Reproductive Medicine explains the in vitro fertilization or IVF process. Parts of this episode are included in another episode entitled From IVF to NICU, One Couple's Road to Starting a Family, also in this same series. You can find and listen to Her Kind of Healthy on Apple, Spotify, YouTube, and news.sanfordhealth.org. And now, Dr. Hansen.
Usually for in vitro fertilization, first we have to do testing so we can figure out the best medications and all that kind of stuff. Then the first part of the process is ovulation induction, where we're giving her medications to stimulate the ovary to try to make more follicles to grow. Because, normally what happens is when a woman goes in the menstrual cycle, maybe one or two follicles will mature and release an egg. What we're trying to do is get a number of them, like maybe 5, 10, 15, 20 of them to grow, and then hopefully we'll be able to get eggs out of them. And so what we do is we start the shots, and the gals have to take shots a couple times a day, I'm afraid. And then once the follicle gets to a certain point and her estrogen's at another point, we have to start her on even another medication to try to prevent her from ovulating. Because once your estrogen gets to a certain level for a certain period of time, it tells the pituitary gland, hey, it's time to ovulate. And if you have only one or two follicles, that's not a big deal because it means it's mature. But if you have 10 or 20, it sends the signal too early and you end up ovulating too early. So we start a medicine to keep them from ovulating. Then we keep going with the medications. And once the follicles get up to a mature size, which is about 18 millimeters in diameter, then we give a shot called HCG, a trigger shot, which completes the maturation of the egg and starts a process of ovulation. Then 36 hours after that, we take the eggs out. And the way we do that is we go back to a little room in the back here that's attached to our laboratory, and anesthesia comes down, puts the person to sleep. Once we're asleep, we can clean the vagina with saline, put a vaginal probe ultrasound, and this ultrasound has a little aiming guide on it. So we put a needle down through there, we go through the top of the vagina, and we just kind of pop into the follicle. It's attached to a pump, pumps the fluid into a test tube. We take the test tube off, hand it back to the guys in the lab. They're sitting under a big microscope that's heated. They pour out the fluid, find the egg, and put it in the incubator. And we do it for the ones on one side. Then we go over and do it for the ones on the other side. Then we take everything out and then wake her up. And then the lab gets the eggs ready, which probably takes them about 4 hours to do. They get the sperm ready, which takes about 4 hours to do. And then depending on the sperm, they either put 100,000 sperm right on top of the egg, or they do what's called ICSI, where they go in, find a normal sperm, pick it up, and inject it into the egg. Then they put it back in the incubator, and the next morning we get to see did it fertilize normally or not. And those that fertilize then can develop. And we want them to get up to what's called the blastocyst stage, which is like a big round ball with a lump over the side. The lump is the inner cell mass. That's what goes on to form the embryo, the fetus, and ultimately the baby. And the outer part is the trophectoderm, and that's what forms the placenta and all the membrane. Now, the blastocyst is only 250 microns in diameter, so you can't really see it. But under a microscope, you can. So what we do is once we have the blastocyst, which usually takes 5, 6, or 7 days, then we can put it back into the uterus. We want to make absolutely sure the uterus is in phase, though, and we want them to have been on progesterone for at least 5 days. So we have two choices. One is we can put the embryo back right away, which is called a fresh embryo transfer, or we can freeze the embryo and come back later and do a frozen transfer. In the old days, we didn't like doing frozen transfer because it actually lowered the pregnancy rate. But recently, they've changed the way they freeze embryos, and now they work just as good as fresh. So now, if there's any reason to cancel, we say, okay, let's just cancel, freeze all the embryos, we'll come back and do a frozen transfer, mainly because better pregnancy rate. And then what we do to do the transfer, once we got the uterus ready, the lining ready, then what we do is have the gal come in with a full bladder, because a full bladder does two things. One is it takes a uterus which is tilted and levels it out so it's more of a straight shot. And the second thing is it lets us see the uterus, because normally you can't see it because there's all that bowel down there and you can't see through bowel with ultrasound. So then we have her lay on the same table where we did the retrieval, put a speculum in the vagina, clean the cervix off. We hand the catheter back. They load a little bit of fluid around the embryo. And then under ultrasound, we guide the catheter up into the uterus. We depress the plunger. You can see the little bubble go up into the uterus. We take it out. We hand it back. They look for it under the microscope to make sure it's out of there. And as long as it's out of there, we let her get up, go to the bathroom, keep her on hormones for 2 weeks. And if she's pregnant, she stays on them until 12 weeks. Now, there's a number of risks associated with the procedure. The biggest one is multiple babies. And we like to follow the American Society of Reproductive Medicine guidelines, which tell us how many to put in to give us the least risky pregnancy and the most likelihood of a live-born baby. And for most women under the age of 35, it's usually one embryo. For those 35 to 40, it's one or two, but no more than that. And it depends a little bit on a number of other factors, but it's usually one, sometimes two, between 35 to 40. The other risk is something called ovarian hyperstimulation syndrome, where the ovaries go crazy. They get huge cysts on them. In fact, the ovary can get so big it can twist, which then cuts off the blood supply to the ovary, which is very, very painful and is an emergency surgical interventions required. They can also their blood vessels get leaky, so they can get fluid in their belly. They can get fluid around their lungs. Their blood can get real thick, so they can get blood clots. So we really don't want that to happen. And there's things we can do to try to prevent that. In the old days, like 10 years ago, it was a lot more common than it is now because we've, expanded our ways to reduce the risk. But overall, our goal with doing in vitro, of course, is a healthy baby and a healthy mom. We're closely monitored by, a number of different agencies. The FDA, the pathology group follows us closely, the American Society of Reproductive Medicine, and then we maintain certification and board certification so that we can provide the optimal care to our patients to reduce their risk and improve the chances of a healthy baby and a healthy mom.
This is Her Kind of Healthy, a podcast series by Sanford Health. This episode is part of another episode entitled From IVF to NICU, One Couple's Road to Starting a Family. You can listen to additional episodes of Her Kind of Healthy and other Sanford Health series on Apple, Spotify, YouTube, and news.sanfordhealth.org.